Chalo, let's start our session to read. We'll be reading wound healing and immunosupport, hemostatic, inflammatory, proliferative, remodeling phase. भी हम इसमें कई सारी चीजें लोग बता रहे हैं. सबसे पहले तो टाइमलाइन याद होनी चाहिए, सारे तुरंत होगा इमीडिएटली. उसके बाद अपना इन्फ्लेमेटरी फेज है जो 2 to 3 days पे होता है. प्रोलिफरेशन फेज है जो अपना 3 days to 3 weeks या फिर 10 days भी मान सकते हो. और जो मैचुरेशन फेज है या फिर रीमॉडलिंग फेज है उसको ईयर्स लग जाते हैं, मंथ्स टू ईयर्स. ठीक है, तो ये बेसिकली टाइमलाइन है जो हमको याद करके रखनी है. और फिर हर एक का एक की इवेंट है वो हमको याद रखना है जो एग्जाम में पूछा जा सकता है, जो उन्होंने क्वेश्चन बनाया हुआ है. तो हम लोग वो टैबुलर फॉर्म बना के इसी में स्टिक कर लेते हैं क्योंकि इट इज इम्पोर्टेंट. पहले इसको सुन लेते हैं ये क्या बोल रहा है.
via your chemotactic gradient, which is known as your diabetes. Right. So they might give you a question where they might ask you to arrange the process in various sequences. Right. Then you have your PMN migration and ECM navigation. How does it occur? Mediated by your integrity. Right. So the migration is a 4-step: adhesion, threading, traction, and retraction. So what does it do? It phases allow the directional migration towards your chemotactic stimulus. Then you have your PMN chemotaxis and signal transduction. So you have your various ligands like your C5A and LTV4 receptor being your CR, and the function is your chemotaxis. Right. Then you have your PMN structure fastener. So what does it do? The enzyme release which degrade the ECM and help the migration. So what are the enzymes that are degrading, helping degrading? That is your elastase and protease. Then you have your oxygen radical burst. So that is an NADH oxidase which generates oxygen, that is your superoxide. Now the superoxide dismutase converts it into your H2O2. Now myeloperoxidase converts your H2O2 to hydrochloric acid. And then we have your pentane reaction which causes the release of your hydroxyl radical, which is highly bactericidal, but also at the same time what it does is damages our own tissue. Right. So over here, potential question to be asked is your pentane reaction. You need to know IN plus H2O2 plus superoxide, that is your hydroxyl radical is your end product. Right. Then the lifespan of your PMN, that is less than 24 hours after activation. How does it get cleared from our body? Via apoptosis or necrosis, and what it is replaced by your mononuclear cells. In sterile wound, it is often not essential. In chronic wound, persistent PMN causes your delayed healing, abscess, tissue necrosis. Right. So again, a potential question that can be formed: what would be the role of your PMN if present in your chronic wound that could cause your delayed healing, abscess, and tissue necrosis? So which factor is not involved in PMN chemotaxis? You have your BEGF, it is angiogenic and not chemotaxic. Which receptor helps CM recognize complement-coated bacteria? The answer would be a CR3. Then which is the key bactericidal molecule formed by PMN during the oxidative burn? That is your hypochlorous acid, which is formed by a hydroxylase in azotylene granules. Which integrase is involved in your PMN adhesion and migration? You have your beta-2 integrase. Right. So this is all about your PMN in your wound healing. And coming down to the macrophages in your wound healing. So the tissue macrophages derive from monocytes via your chemotaxis process. So they appear 4 to 48 hours after injury and peak at 48 to 96 hours. So what is the chemotactic stimuli for it? The chemotactic stimuli include your bacterial product, C5A, from the cytolytic, collagen, PD, beta, and PJ beta. So integrin and ECM interaction, what it does is that it triggers your transformation to full macrophages and upgradation of EGR2 in form of EGR2 and PFOS. So receptors and recognition, basic receptors are with your FC gamma are ligand is your IgG, function being oxidized bacterial secretion. Then you have your CL1 CRP, which is ligand being your CCB, which causes a complement mediated phagocytosis, and then you have your QPD, with cytolectin ligand, and the function being your adhesion and stability. Right. So the macrophage effector function, that is your phagocytosis of your suboptimal neutrophils, bacterial debris, and your foreign particles. Then the free radical production, that is caused by the Gs by IL2 and V, your reactive oxygen species and negative oxide, and the eicosanoids, they release what? Your thromboxane A2, EGF2 alpha, FTP4, STP4, and what it does is that it promotes utilization, neutrophil chemotactic. The matrix remodeling by the macrophages, what it does is release the MMB, that is your 1, 2, 3, 9. What is the function? It brings the extracellular matrix for your cell migration, and also at the same time, what they do is they regulate the matrix turnover. They are controlled by CMP pathway, 18 by NSAID, phosphostrate, positive, and retinol. Right? Then we have the various cytokines and the growth factors that are released along with the function. Again, a very important table. We have your IL-1, acute phase, fever, increase, adhesion molecule, collagenase, and cytokine proliferation. CNS alpha, you have your early indicator, vascular permeability, I1C, IL-6, you have your beta T cell activation, active acute phase protein, cytokine growth, TGF beta. Again, you have your cytokine activation and collagen synthesis, CGDS, has been a chemotactic and mitogenesis, CGS indigenesis, CGS has a role in your keratinocyte validation, and nitric oxide is your signaling molecule and bacteria. So this cytokine is released by macrophages that stimulate and fever and neutrophil activation, as we discussed earlier, that is your I1. Macrophage drives MMP8 in your ECM remodeling, which factor releases macrophage activation and free radical release, that would be your MMP2. Then elevated CNS alpha in chronic wounds causes your delayed wound. Right. So now moving down to the macro against the lymphocytes in wound healing. So the macrophages mainly origin from the monocytes, peak the activity around 48 to 96 hours, and the main role is for the orchestration of an inflammation to your proliferative cells. Right? The transformation stimuli we have already discussed, that is like alpha, TJ, beta, and TJ. Right? Then the macrophage has two phenotypes, that is M1 and M2. So M1 is your inflammatory phase, and M2 is your proliferative phase. The main function of your macrophage is for phagocytosis of debris, phagocytosis, growth factors, and matrix remodeling. Then you have your key cytokines from the macrophages. So IL-1 is increase in the body mood. Then you get alpha, that is early increase in good when prolonged for this time. IL-6 decrease in H valvular and fetal wound, again a potential MCQ. Then you have your interferon gamma, which is used in hypertrophic and keloid treatment. Right? Then the growth factor signaling, you have your TJ beta 1 and 2, which increase phytosis current, TJ beta 3, increase phytosis, and scarlet fetal. So again, a potential MCQ that can be asked. Then you have your TGF alpha, which is responsible for your epidermal growth and infusiogenesis, and TGF, that is responsible for your collagen and PD synthesis. Right? So macrophage depletion study. So if there is pre-injury depletion, there will be decrease in revitalization, infusiogenesis, and cytokine and contraction. Post main depletion usually have no major effect because their role is mainly towards the early days. And then in the fetal model, you have healing occurs normally, inflammatory cells are not essential. Right? So these are your various important points regarding your macrophage. And then again, some important points regarding your interleukin 8, which we have discussed. Macrophages and the fibroblasts are important source, and the main function is your CNS chemotactic adhesion molecule. Then we have the lymphocytes in wound healing. We have T cells that peak around day 5 to 7 and regulate healing and cytotoxicity. Then you have your beta cells that is healing as dose motility. Then you have the cytokines, the IL-2, TJ beta, TNF alpha, interferon gamma. Then you have your EBC activation by macrophages with the antigen stimulate T cells. And interferon gamma effect, that is decreased prostaglandin, decreased collagen synthesis, and increased inflammation. So these were your important lymphocytes which have roles in your wound healing. So some important MCQs, just to summarize your lymphocytes and the macrophages that you have read. This growth factor is giving approved for wound healing. So that is your PDGF, PE, then which macrophage should have primary remodeling your proliferative phase, that would be your N2. Then which TGF beta isoform limits fibrosis and is dominant in fetal wound healing, that would be your beta 3. Then this cytokine regulates the prostaglandin synthesis production, so that would be your interferon gamma. Right. So any doubts so far before we move on to the next section of qualitative phases of wound healing? Shall we continue? So the qualitative phases of wound healing begin at day 3, not from 2 to 4 weeks. The main objective is to re-establish the tissue continuity. Again, we have the key cellular that being the fibroblast. What is its function? Collagen, stimulated by your BDF, lymphocytes, collagen, especially type 3, protoglycans and gas. Then we have your later converts into myofibroblast, which causes your bone contraction. So this bone fibroblast, what it does, proliferate less and produce more collagen, and then sensitive to your cytokine rich environment as the IL-1 and BDF beta. Right. So lactate accumulates around 10 millimoles, which stimulates the collagen synthesis. Now, which by this pathway is EDP lipomyelination. Right. So again, a potential institute that can be asked. Then we have your angiogenesis, that is endothelial cells migrate from your intestine, so they are typically stimulated by which factor? EDF, TGF, beta, TNF, alpha. So BGF basically produced mainly by your pixels, that is the macrophages, and then specific to your endothelial cells. Then we have your revitalization, they are mediated by your keratinocytes, and they migrate over granulation tissue from both the tissues, and they are essential for your closure and your better restoration. Then we have the role of collagen in proliferation. So, as we discussed earlier, initially it is type 3, mediated by your activated cytoplasm, and increased their size of growth. Usually by your 30, and then later replaced by which type of collagen, that is the type 1, your 3, your right. So they might even ask you this question, type 3 is converted into type 1 in which phase of your bone healing, right? So which of the following is the main chemotactic factor for fibroblast bone healing? That would be the BDF, a component of granulation tissue, so the new capillary, then responsible for bone contraction. In proliferative phase, that is the myofibroblast, and which of the following is increased in bone and promotes collagen synthesis by ADP, like ribosylation. So the answer to that would be your lactate, right? So these are your some lactate division points. Any doubts? We move now to proliferative phase, that is the granulation tissue and angiogenesis. So the granulation tissue composition mainly are your capillary, cytoplasm, macrophages, and provisional matrix. The main role of capillary being to deliver the oxygen and nutrients, cytoplasm being the ECM construction, macrophages being a growth factor and cytokine production. And the provisional matrix main role is for the scaffold of fibrate and fibronectin for migration. Right. Then we have your fibroblast, which migrate via your this molecule, PDF beta and PDGF, and this produce the collagen type 3, and they can also differentiate into your myofibroblast. What is the role of myofibroblast? That is your contraction. In good fibroblast, increase collagen synthesis, decrease proliferation, and increase packet construction. Right? Then we have your angiogenesis. So the main step in angiogenesis is the basement of degradation, endothelial migration, human formation, capillary maturation. Right? So they might again give you a simple question from the various steps of your angiogenesis. Right? Then the adhesion molecules include your beta 1 integrase, beta 1, and TV beta 3 integrase. So these are your key growth factors in angiogenesis that you need to remember definitely. Of which the important would be your TGF beta, where the source is from your platelets and your macrophages for the ET migration, active remodeling. Then you have your EDFA. What is A the source? That is macrophages, keratinocytes, and fibroblasts. What is its action? Early angiogenesis and in 5 to FLT1 and BGFR2. Then when we talk about BGFC, it is main source in the macrophages and it causes increased permeability via which that is with BEGFR3 and also activates your BGFR2. Then you have your placental growth factor. What is its source? Keratinocytes and disease and syntagmatic plus BGF. Then talking about your fibroblast growth factor, its main source is your again your disease and it stimulates your angiogenesis plus fibroblast growth. Then we have your heparin, which comes from your intracellular matrix. It binds your angiogenic factor, which increases your easy migration. Right. So BGFA is impaired in diabetes, which is restored with your exogenous BGF. So just to summarize in form of the MCQ, which of the following binds BGFR2 and stimulates endothelial production? One would be your BGFA, which modulates the endothelial cell adhesion during your angiogenesis. So we have your BCAM1, which modulates your endothelial interaction during your tubulogenesis. Then which integral endothelial cells facilitate binding to fibrillary fibronectin? That would be your ADP-C. And following increases the collagen synthesis by ADP ribosylation, that is your lactate. Right. Now coming down to the angiogenesis and fibroplasia in your proliferative phase. So the various mechanisms of angiogenesis would be your endothelial activation, endothelial migration, and human formation. So endothelial activation, cytokine that induce your MMPs and plasmids, integrate the basement membrane. In endothelial cell migration, scaffold is by your fibronectin, fibrinogen, and hyaluronic acid. And human formation, we have some vessels which cover into arterial venules and by further undergo apoptosis. Right. So the various growth factors in your angiogenesis include your FGF1, VGF, TGF, beta, TNF alpha, IL-8, heparin, lactic acid, and DHGF. Right. Then skipping on this factor because we have been reading it continuously in the previous section. Right. So, but take a look at it. Definitely the important one being TGF, beta, TNF alpha, and infinity A. Right. Then we have the VGF signaling. So that is the FLT1. Main function being your vascular organization area. That is the EC proliferation, migration, and human formation. And then you have your BGFR3, which is lymphatic and EC permeability activated mainly by your BGFC. Right. Then talking about the crosstalk. So we have the HIF1 alpha, which is induced by hypoxia, which causes increase in BGF and NO synthesis. Right. So BGF stimulates NO synthesis and NO enhances BGF production. So this is for critical for your vascular permeability motility and your easy proliferation. Right. Then regarding your fibroblast biology, there is a last phase that is day 2 5, and the time needed for the mesenchymal cells to form into fibroblast. Peak activity is occurring when, that is on day 5 to 14, and then they decline usually after 4. Right. So the life cycle of these fibroblasts, mainly from the mesenchymal cells, stimulated by your CDGF, DJ beta, T and alpha. And what are your functions? TCA synthesis, autocrine stimulation, and contractile signaling. Right. Then you have your growth factor requirements. Right. So what are your growth factor requirements? CDGF, so that is your chemotaxis and TCA stimulation. TJ beta causes CC fibroblast differentiation and CDJ-CD. NGF2 causes autocrine proliferation signal, and we have a EGF and IGF-1, which is needed for the bacterial fibroblast proliferation. Right. Then coming on to the maturation and the collagen turnover. So it begins around 4 weeks, and the balance between the synthesis and the destruction. So what is your main outcome? Increased cell size and family regression, decreased SAL and mucopolysaccharides. Right. Which factor initiates angiogenesis in first 3 days? That is your HGF2. Which transcription factor is responsible for VGF under hypoxia? It is your HIF1 alpha. Then primary function of fibroblast in bone healing is your collagen synthesis, and the lag in collagen deposition after injury is required because of the time of fibroblast differentiation. Right. So summary is both similar to DGA and nitric oxide. So can you get your question like what we are trying to wanted to know? What should I repeat? Yes, so that is exactly what we are talking in crosstalk. VGF stimulates your NO synthesis and this enhances your VGF production. So here we have this crosstalk, right? So both, what exactly is the doubt over here? I'm not able to get your doubt over here. Please could you clarify? Yes, that's exactly what we are talking in crosstalk. VGF stimulates nitric oxide and that also stimulates VGF. Yes, so that's exactly what is the crosstalk. So now we move ahead. So we have the matrix synthesis and maturation contraction usually. Right. So the collagen synthesis pathway, we have the various steps, that is translation, hydroxylation, glycosylation, supersonic, extracellular processing, and cross-reacting. Right. So we need to know some important parts over here. So like in translation, what it does is it forms the protocollagen and the key component is your glycogen. You need to remember this. It's like in every third residue. Right. Then we have hydroxylation, that is of O and NYS in your endoplasmic reticulum. So what does it mean? O2, iron, vitamin C, and alpha Kg. Then we have your glycosylation that adds galactose and glucose on which amino acid, that is a hydroxylation. Then we have your triple helix. What it does? Forms procollagen, that is 3 alpha helices with registration peptide. Now in extracellular processing, we have the peptide C and causing your polymerization and cross linking. Now you need to remember over here that it means your acid oxidation. Then we have your cross linking, that is your covalent bonds which increase their size strength, and it happens in your maturation phase. You also need to remember the term covalent bonds. Right? Examiner might confuse you by giving some other terminology of bonds over here, right? So you need to remember the bonds that are being formed are your covalent bonds. Then you have your proteoglycan synthesis, which are synthesized by your fibroblast when during the first 3 weeks. Then the sites are your sematic sulfate and chondroitin sulfate. What is the role? Role for checkpoint for collagen fibril assembly. Now, the interaction part. So this proteoglycan sulfation, it regulates your collagen configuration, and it is incorporated into your collagen scaffolding, and they decrease as your full mature. Now, regarding your matrix maturation and remodeling, so when does it begin? It begins after 3 to 4 weeks and lasts up to 7 months. Now, it is regulated by a balance between your collagen synthesis and collagenolisis. So, what is responsible for your collagen synthesis? That is your fibroblast. Collagenolisis, that is your MSC. Right. The timeline week is early. The main components are your fibronectin type C collagen, and in the late you have your type 1 collagen, which causes your increase in your SI strength. Then the mechanical strength. So they depend upon the collagen quantity and quality. So fibrillin, that is your glycoprotein, essential for your elastic fiber. The maximum strength is your 70 to 80% of the original tissue. So bone contraction, that is your centripetal movement of the surrounding tissue to close bone. Then you have your bone contracture, that is the excessive contraction causing functional limitation. That is the example of joint, eye, and arm. Then you have your mechanism of contraction, which is mediated by your myofibroblast. So the fibroblast expressing alpha smooth muscle actin, they usually appear on day 6, peak by day 15, and are gone by 40, which attach via your fibronectin, that is your link cytoskeleton to extracellular matrix. The contraction is driven by which fiber? That is your active myelin sheath fiber. What they do, they generate traction, and the tension stimulates further contractile machinery. Now it is limited by conjunctive and cytoskeleton. Right. So the various MMPs that intervene in contraction, just your MMP. So what it does is that allows collagen and fibroblast detachment and contraction. T1 intervenes, immediate fibroblast, binding modulated by the TJ beta 1, and then you have your TJ beta 1, which increase your beta 1 integrin expression and acid contraction. Right. So vitamin essential for hydroxylation of collagen, that is vitamin C. Type C is the which type in your which phase? Type 1 in your remodeling phase. Which of the following cell mediates the bone contraction? You have your myofibroblasts. And then what is the effect of your TGA beta and collagen binding? It does is that it increases your collagen synthesis and decreases your MMP via the M pathway. So basically, TGA beta is pro-fibrotic and it suppresses degradation. Right. So, any doubt so far? As we continue with the acetylization in your bone healing? Yes, so the various phases in your acetylization are attachment, migration, proliferation, differentiation, and classification and keratinization. So, we need to know these definitions. Why? They might ask you which of the following is correctly matched regarding the phases of acetylization. So, attachment is your marginal facial keratinocyte to SIBO, heavy desmosomal attachment. Then you have your migration, that is a leapfrog or tumbling across your provisional matrix. Now, what it is aided by your ECM cues. Then you have your proliferation. So, what's device over there? So, the basis keratinocyte which rapidly divides behind the leading edge. Then differentiation and classification, release started, peripheral, that is a back side squamous, peripheral, and keratinization, which forms the impermeable barrier of bone. Right. Then we have the various kinetics and patterns. So it is initiated when by the loss of contact inhibition and the ECM exposure. The cell move over a short separate viable tissue using collagenase and plasminogen activator, as well as plasminogen activates your NMP. So these keratinocytes are phagocytic. What they do is during migration and cells return to columnar shape post coverage to stack. So these are your various stimulators for revitalization, which includes your EGF, TGF alpha, beta, BFGF, CTGF, and IGF1. Right. So just remember the name and the important action. We have discussed the important one before, so please try to remember them. Then we have your basement membrane zone component. So again, this is a very important part. What are your various layers? Lamellar nucleus, densa, and anchoring cycle. So the components include laminate, thiosulfate, lipocollagen, and cyclic collagen. Right. So basement membrane must regenerate if damaged. If else, it would delay epithelialization. So the various cell matrix interactions include again via integrin, fibrinogen, chromosomal, and fat. So which ECM protein primarily guides keratinocyte migration? So that is your fibronectin. This enzyme produced by epidermal cells degrade ECM, that is the collagenase, MAP1, leapfrog, and tumbling mode of epithelial scheme. This phase we discussed, that is the epithelialization. This factor delays epithelialization the most, that is your loss of basement membrane. Right. So any doubts so far? Is the seed fine? So now we move on to the extracellular matrix and collagen. So extracellular matrix is just not the scaffold, but a dynamic regulator of cell migration, differentiation, proliferation, and signal transcription. So what it is composed of? Attachment proteins, galvanized proteoglycans, and cyclic proteins. So what are your various phases of ECM in bone healing? You have a provisional matrix, early matrix, and late matrix. We have discussed this before. Now the dynamic ECM remodeling. So what it is regulated by? Mainly the balance between the deposition and purification. So we have the enzyme that is the NMP1, the sodium fibroblasts, which causes collagen breakdown. Plasmin is active with collagenase, and MFP9 which causes your ECM degradation. Then your integrin and ECM interaction. So your integrin, they are your plasmin receptors connecting cytosolic and extracellular matrix. Binding to the fibronectin triggers your cell migration, adhesion, and proliferation. And clustering into focus adhesion, they basically modulate your signal strength. If you have your ECM and cell feedback, so the cytokine signaling is your ECM dependent process. So IL-1 increases MMP1, TGF beta also increases your MMP1, we discussed before via TMP, and TGF beta also increases your ECM synthesis. Loss of anchorage, that is decreased cytolectin, what it does is your metastatic serotype in tumor. Again, a potential NP2 that can be up. Then we have your fibrous sealant and TGF beta in your extracellular matrix. So fibrous sealant is your artificial provisional matrix. So it's supplemented with TGF beta. What it does is that it increases ECM synthesis, reduces MP9 activity, increases cell migration, and increases cell strength. Now, a few important points regarding your collagen. So they found your triple an important question. E alpha chain, G by X by EP, where X is your protein and Y is your hydroxy protein. So this all are the potential one-liners that can be asked. So protein is for your rigid conformation and lysine is for your tight fat. So you have your tubular collagen, which are the 1, 2, 3, 5, and 11. Now regarding your types of collagen, you need to remember that type 1, main function is stem cell and type cell. Type 3, you have early ECM, rival ECM. Type 4, you have your mesh structure. Type 7, you have your basement membrane to dermal attachment. Then you have your type 17, which is a heavy desmosome, which causes your transmembrane connection. And then your endoplasmic precursor, that is a vasodesmosome membrane, you have your type 3. Right. Another important ABQ, type 3, increases in fetal skin and early bone healing. Which collagen type is most prominent in early bone healing? Type 3. The provisional ECM is primarily composed of lipid and fibrinolectin. This enzyme activates your MMP1 in the ECM, plasmin, TJ beta, increases ECM5, which mechanism decreases collagen. Right. So regarding your collagen and elastic fiber synthesis and bone healing, so the various intercellular phase, I would be wanting you to know the step, that is translation, signal peptide glycosylation, triple formation, and transport to Golgi. Then you have your extracellular phase, So the important steps in your extracellular phase are your pro-peptide cleavage, fibril assembly, cross-linking, and fiber organization. So, what are your clinical impacts of your defective collagen synthesis? Decreased vitamin D, you have curly features of like sleep vessels, leading them to protein. If you type C collagen, you have your error and loss, and the hyperactivity and joint hypermobility. So, these features would be your clinical to identify the defect and the pathology. And then we have your decreased type 1 collagen. That is a complicated imperfect form. Then you have your fragile bone and loose flare up. Right. So this is rather a very important clinical question that can be found from type 1 and type 2 collagen, that is error and loss and oxygenous and imperfect form. Then we have your regulators of collagen synthesis. So what are your inhibitors? Glucocorticoids and interferon gamma, and stimulants are your TJ beta, IGF-1, IGF-2 vitamins. Then regarding your elastic fibers in ECM, the next synthesis steps are your topoelastic species, like processing, deposition, and microfiltration. Then the regulators, again the inhibitors are your glucocorticoids and DHA. Then the clinical derivation of your elastic effect. We have the key fibrillin. What it does is Marfan syndrome. So what are some of the key features? Aortic aneurysm, lens dislocation, and long. So this would be the clinical clue to identify the Marfan syndrome. Then you have the elastic syndrome, elastic. You have your arterial narrowing and your intimal hyperplasia. So over here we need to remember this two important syndromes, right? That is the Marfan syndrome and your elastic mutation. And in your collagen, we need to remember your alert and loss and your osteogenesis imperfecta. So, which are the following essential for protein hydroxylation in collagen synthesis? Vitamin D. Protein deposition requires your fibril cathode. With enzyme crossing glycine using collagen, we have it as lysate oxidase. Which type of collagen increases in early damage tissue? This is the type. Now coming down to the glycosaminoglycans and the photoglycans. So, the basic structure is your repeating disaccharide unit, sulfated amino sugar plus uronic acid. They are highly negatively charged and they attract sodium, which, as a result of which allows you to draw water. The main role is server competitive strength and space for cell migration. So the main four types of glycosaminoglycans we have hyaluron, chondroitin, methylsulfate, and static cell. Right. So just in short regarding some important features, they are not sulfated, not attached to protein core, have a role in fetal healing, and there will be burning chronic wound healing. So that are the main points of the hyaluronic acid. Then you have your proteoglycans. It can be sulfated or not, creating hydrated gels for cell fusion and molecular transport by cytokines, CS and protease and moderate cell gradient effect, and they're part of your PCM and transmembrane core receptor. Right. Then we have your main functional roles, that is your reservoir, activity, and targeted action. Then we have your fibronectin. So define the ECM plus entity. Soluble form is in plasma, crossing and oxidation and purging are the functions. And the insoluble form, you have your ECM that is coupled to active cytoskeleton in your cytoplasm. So the main mechanism is the integrins plus actin myosin, which causes your enzyme matrix assembly. So we discussed about the basal lamina. Now the ECM degradation, so we have energies and your serine protease. Right. So coming down to the important MCQs, that is which that is not sulfated and non-bound to protein. That is your hyaluron. Which ECM protein modulates protein healing and phagocytosis. So this one, that is fibronectin. Which enzyme family is key in ECM degradation during repair? That is your NMP. And lamin binds all except your elastin because it does not interact with it. Right. Then coming down to the last phase of your wound healing, that is the remodeling of the maturation phase. So what happens in the collagen remodeling? The type C is replaced by type 1. This is a very important question which has been asked. The total normal type 1 is to 3 ratio, 4 is to 1. Right. So be careful where they're asking you type 1 is to type 3 ratio, or they are asking you type 3 to type 1 ratio. Right. When you're asking type 1 is to 3, the definitely answer will be 4 is to 1, but over here, if they're reversing, your answer also does get reversed. Right. So we discussed about the bone contraction and contracture and the role of myofibroblasts. So the indicators of contraction are your corticals, which include the microtubules, and the cytoplasmic B, which includes your microfilaments. Then the key enzymes, we have beta 1 interleukin, TJ beta 1, and your NLP3. Right. So which when does maximum enzyme strength of a wound occur? That would be 12 weeks by how much? That is 80%. Which collagen predominates in the mature wound. Look at the word mature. So the word would be type 1. Myofibroblasts are characterized by the presence of, which would be your alpha smooth muscle actin. So they are the stress fibers of the actin, which is your microfibroblast INT. And then most involved enzyme in your ECM remodeling for contraction is your stromalizin or NLP. Right. Then the various growth factors in your wound healing and contraction. So the growth factors are the polypeptides, which regulate as discussed so far, migration, proliferation, and differentiation. So the main mode of action include your autoclean, paracrine, and endocrine. So what is autoclean? Acts on skin cells that disease. So what is an example of it? That is your TGF beta in fibroblast. Then you have your paracrine. So what it does is act on the adjacent cells. Example being your TGF, completion, and fibroblast. Then you have your endocrine, that is via your blood stream to the side. What it does is hormonal shift, and it has very rare role in food. Right. Then the various receptors, you have the surface binding ion channel, gluconeogen, I think that is the line like complex sterilization. Right. So these are your various principles. Growth factors in your wound healing. That is the PGF, PG beta, FGF, EGF, PGF, IGF1 and 2, human equity factor alpha. So let's read this table wise once again. An important table. We have been revising, but let's summarize it over here again. PGF, chemotacin for fibroblast, monocytes and smooth muscle. PG beta, anti-inflammatory, increase collagen and decrease matrix proteinase. Then we have your FGF, that is your angiogenesis, granulation and crystallization. PGF, we have your epidermal cell necrosis. PGF, you have your angiogenesis and vascular permeability. And your IGF1, you have your stimulating fibroblast proliferation. And GGF, you have your epithelial cell migration and proliferation. And GS also you have your gliomastic cells, increased cytokines, and HIF1 induction. Right. Now coming down to the bone contraction, that is the centripetal movement of bone margin, mainly in secondary intention healing. So myofibroblasts is the muscle contraction cell. They derive from fibroblasts, it's alpha smooth muscle actin. So the other key point that we need to remember is myofibroblasts, chest fibers, causes your contraction, and bone contraction starts before your myofibroblasts are closed. Now, why would that happen? Because of the fibroblast cytoskeletal organization. Right. So which are the following growth factors play primarily promote angiogenesis. Straightforward BGF, which of the following cells initiate bone contraction, that is your myofibroblast, which growth factor inhibits matrix metalloproteinase and enhance your collagen synthesis. You have your PGF beta, and what is the main signaling mechanism of growth factor? That is your surface receptor phosphorylation cascade. Right. So any doubts so far? So this was your basic of your wound healing, where the entire phase, the various phases of your wound healing was discussed in detail. So baby and love, basic three, the first table that we discussed regarding the various steps, that is your main focus on your baby and love. So that is definitely your one more way you need to go on these steps. And we get detail, the molecular details, which cells is being as what it was, and have been mentioned in samples. So yes, questions can be based on your, but your basic concept of the basic stages of wound healing, we cannot make a mistake on that. Right. So now we move down to the healing in the specialization. Right. So far so good. Any doubts? Shall we begin our discussion on this? So now we will begin our discussion in normal healing in specific tissues. So we'll have a discussion.